So the next symposium is again very interesting. As from the previous symposium, if people do have questions, speakers are available. You can please contact them during this time to ask them questions. So can I invite our chairpersons for the next event, Professor Dr. Revati Janakiraman and Professor Padma Ma'am, Professors of Obstetrics and Gynecology, to chair the next sessions.
Good morning, dear friends. Thanks to the organizers for giving us this opportunity to correct the menstrual irregularities or infertility, but hirsutism poses a great challenge. And here is Dr. Chitra Selvan, who is going to clear our doubts and how to manage difficult hirsutism. She is Associate Professor Endocrinology, Ramaya Medical College, Bangalore, and she graduated from Madras Medical College and DM Endocrinology in IPGMER, Kolkata. And he has received A.V. Gandhi Award for Excellence in Endocrinology in 2015. And she is a member of National Academy of Health Sciences. And he has got to her credit more than 40 publications in national and international journals. Over to you, Dr. Chitra.
Thank you so much, ma'am, for that kind introduction. My heartfelt gratitude to everybody on the organizing team of Trendos for this invite. I'd never miss up on an opportunity to visit Tamil Nadu, especially Madurai. The chairperson has highlighted about how common hirsutism is and about how PCOS is probably the most common cause of hirsutism. I'm going to restrict my discussion to present maybe the sinister causes of hirsutism or the causes which could essentially portend something dangerous or serious, but they present as hirsutism to our clinics. And this is an important thing for us to remember because as PCOS is increasing, we are also noticing that hirsutism presentation is increasing in women, both in reproductive and non-reproductive ages. So a quick brush up about hirsutism. We all know that it is excessive hair, but the hair has certain characteristics. It usually has to be pigmented, thick and coarse to differentiate it from another condition called hypertrichosis, which is usually like the baby hair which we see on newborn babies, but this is different. And the location of the hair growth which is significant is in areas where there is androgen dependency. So that includes a few areas, and I'll show you. So as you can see, it's pigmented, thick and coarse. Now the connection between this increased hair growth on the face is that the androgen exposure to the hair follicle can cause the hair to grow in androgen dependent areas, but the variations of hirsutism could be acne, because in acne in the same hair follicle the pilosebaceous unit undergoes hypertrophy, or similar presentation could be that there is hair loss or referred to as androgenic alopecia. So when somebody presents with hirsutism, that is one presentation of increased androgen in that person. We should also be looking for acne, also be looking for androgenic alopecia. That's important. Before we move on to evaluation, it makes sense to kind of quantify the hirsutism to kind of get an idea. And we will now learn about the fallacies of this scoring itself. I think this everybody knows. This is the modified Ferman-Galway hirsutism score. Essentially, there are 9 areas which are androgen dependent, and we score from 0 to 1, depending on whether there is, 1 to 4, depending on whether there is hair growth or no hair growth. It's a very visual, subjective score, but most times we are able to. But of course, it's important to make sure when was the last time they got hair removal done, and then to get a baseline assessment of this. There are a few limitations of the score. It doesn't include certain areas which are androgen dependent, like for example the sideburn. That's a very common area where women come and complain that there is increased hair growth, but it's not represented on the scale. Also, the other area is probably the buttocks. So apart from that, this is a scoring system which is fairly reasonable to use in clinical practice. If you're trying to ask how common is it, the prevalence studies are from various corners of the world. The prevalence ranges from, let us say, 10% to about 30 to 35% of people, depending on the population you're screening. But from India, looks like 10% is what we are looking at. And if you're trying to look at beyond what score of hirsutism did they use to say that it is a clinically significant hirsutism, Caucasians seem to have greater hair in androgen areas as compared to Asians. But in this context, when we talk about Asians, we're probably talking about people from Thailand or China. Not much data from India, but Asians overall tend to have lesser hair than Caucasians. So maybe the score of 8, which is considered as the cutoff for Caucasians, is probably slightly higher for us. Asian studies tend to use a score of 3. I don't think we'll find too many women who have a score less than 3, right? So that is something to be kept in mind as well. So the cutoff is not quite certain for our population. I'm going to begin with case presentations so that we can get into the habit of the evaluation of hirsutism and show you the various sinister or the dangerous causes alone. So this is a 19-year-old lady. She presented with increased hair growth on the face, also had secondary amenorrhea and a change in voice since the last 6 months, and this happened during the COVID pandemic. So on clinical examination, her score, which we just spoke about, was about 16 by 36, that's moderate. But since there was also deepening of voice, she received a full clinical examination which showed that there was enlargement of the clitoris as well. So she underwent evaluation for the same. Her TSH, prolactin and 17-hydroxyprogesterone were normal. I'll come to why we did 17-hydroxyprogesterone. Total testosterone was at 759 nanogram per deciliter. Normal range for women is around less than 60 nanogram per deciliter. DHEAS was also found to be very high. I will come to what DHEA is, and her steroid levels were normal, and an ultrasound of the abdomen revealed a 10 centimeter into 8 centimeter mass in the right adrenal gland. So androgen production in women has predominantly 2 sources, ovary and the adrenal, right? So the adrenal produces testosterone, but it also produces DHEAS. DHEAS is almost specific for the adrenal. Although in some situations of an ovarian tumor or so, you can find elevated levels of DHEA and maybe also DHEAS. But if you find DHEAS elevated more than testosterone, probably you're looking at an adrenal source, and our patient did have a lesion. So we went ahead and did an adrenalectomy, and it showed an adrenocortical carcinoma, right? So this was a carcinoma in the adrenal gland which presented as hirsutism, where the cortisol secretion was normal. This is very, very rare, but not so uncommon. So after the adrenalectomy, of course, we had normalization of the DHEAS and testosterone, both the androgens, and we also saw a reversal in the hirsutism, and her cycles resumed. So the point here is, when you're looking up patient for hirsutism, while it's important to quantify hirsutism, we should also be looking out for signs of virilization, which is due to either a large exposure of androgen or a longer duration of exposure to high levels of androgen. The features of virilization include temporal balding, like you can see in the image, atrophy of the breast, clitoromegaly, like we said. So maybe indices are difficult for everybody to remember, but if the clitoral length is greater than, let us say, 1 centimeter, there is something to be evaluated further. A change in the body contour or the body habitus of the woman, and temporal balding. All of these are red flags which need further evaluation. So the duration and progression of symptoms are also important. If it is recent onset or rapid progression, it's likely to be an ominous condition underlying. And if you take a look at pure androgen secreting adrenal tumor like our patient did, the mean age of presentation is what I want the audience to notice. It's about 17 years. So this is an age group where they come, and we are very likely to say this is peripubertal onset PCOS and the Madri. So this is something to remember, that there can be sinister causes as well. So the learning point is, if testosterone level is greater than per deciliter, suspect an androgen secreting tumor. If the DHEAS is elevated more than 800 microgram per deciliter, suspect an adrenal source. I hope that was clear. We move to another age group now. She is 66 years of age, Postmenopausal. She was a choir singer. She was actually sent over to me by Dr. Lily John, who is a very astute clinician. She was in the same church, saying her voice has changed and her pitch is off in the choir. She came to us saying she's having temporal hair loss and just a few strands of hair under her chin. Nowhere else, nothing else. Just the 2 strands were growing too long. In fact, she had to go to the parlor to pluck it out almost every 2 weeks. So, apart from that, on clinical examination, she looked muscular for a 66-year-old with obvious loss of hair in the temples. So, we know now that we need to get a testosterone level done. So, the testosterone was 530. So, think tumors if levels are more than 200. DHEAS was normal, androstenedione normal, thyroid normal, and renal and liver functions normal. We went ahead to do an abdominal MRI to find out where the source was, and everything was normal. What do we do now? So we went ahead and did a GnRH suppression test. So now we don't know if the androgen is coming from the ovary or the adrenal. To try and differentiate, if you give GnRH, the ovarian source, if it is ovarian source, will get suppressed. And that's exactly what happened. After injection, about 4 weeks later, when we retested testosterone level, it came down, which meant that it was under GnRH control, partially at least. So we went ahead and got a bilateral salpingo-oophorectomy done, and the diagnosis was a granulosa cell tumor. This was quite a bit of a surprise. This was not the tumor we were expecting. In this age group, the most common lesion with this presentation is probably Hylas cell tumor, which is mostly benign. But granulosa cell tumor has about a 35% malignant potential. So, and mostly they don't secrete androgen, and this was one which was secreting androgen. So this is again a sinister cause of hirsutism in postmenopausal. And postmenopausal hirsutism is quite common because after menopause, the relative ratio of testosterone to estrogen is altered. So we do see new onset hirsutism, but it's important to tie it all together with the other features of virilization as well. So this got presented at a recent conference as well. So mild hirsutism also can have an underlying sinister cause. That's the point I'm making. The Ferriman-Galway score in this patient was just 3. Take it in with all the other clinical examinations. So moving further, this is a third person, 19-year-old, went to the dermatologist for laser therapy and not to any gynecologist from the hinterlands of Karnataka, presented with amenorrhea, no breast development, deepening of voice, and maybe the mother says there was something abnormal around the clitoris, but we never evaluated it, right? So this was the clinical presentation. So here there are many, many red flags, right? That there is primary amenorrhea, no breast development, so definitely this requires detailed evaluation. So the testosterone level was found to be high again, but the 17-hydroxyprogesterone was also found to be high. So the diagnosis was classical congenital adrenal CA, which was simple virilizing form. Usually this is to be picked up just after birth or maybe a few years after birth, but we live in India where access to healthcare might be a challenge for many of us. So it's not uncommon for us to find women reach right up to the age of 17, 15, 16 and present with hirsutism, and all the other symptoms are forgotten. So this is a condition in which there's a block in one of the steroidogenic hormones, which means that the substrates above it get shunted into the production of testosterone. So there's increased androgen and hirsutism as well. Now, another variant which is likely to present is the non-classical CH, which is the same enzyme, but a lesser, probably a greater degree of enzyme activity is present. They might not present with such great hirsutism, might be milder versions, almost like PCOS that we see in clinical practice. But it's an important condition to recognize because it has repercussions in terms of, let's say, the child's risk of getting CAH in the future. We might need to offer genetic counseling, so we might need to pick this up in clinical practice. So I think while PCOS is the most common cause, there could be mimickers of PCOS which can present with just hirsutism. This is a case report published from Tamil Nadu. This is from the SRMC team, Karthik and team. So she is around 16 to 17 years of age, secondary amenorrhea, facial hair, with a Ferriman-Galway score of 21, total testosterone of 464, again tumoral range, DHEAS normal, But 17-hydroxyprogesterone, which they did, was 11.2 nanogram per ml. Now, sometimes when you're thinking of ovarian sources of tumors, you can have an elevation of precursors, which doesn't necessarily mean that there is CAH underlying. So this was the thought process with the treating team. Went ahead and got an imaging done because we need to find out where the testosterone is coming from. They found a lesion in the ovary, underwent further evaluation with other markers, underwent a surgery, and the diagnosis was Sertoli Leydig cell tumor of the ovary. So this is also a rare cause of hirsutism in younger age group women. After surgery, many of the parameters settled down except for 17-hydroxyprogesterone. So they made a diagnosis of non-classical congenital CAH along with an ovarian tumor. After this, when I went back and reviewed, there is an increased risk of ovarian tumors in women who have CAH on treatment or who have NCCAH. So this is also something that we need to monitor. During CAH, we are replacing steroids and monitoring the testosterone levels. If there's a sudden spike or if there's sudden worsening of virilization, maybe we should consider this. So another woman, 23 years of age, now the audience is very, I think, tuned to this. She presented with very minimal hair growth on the face, and this is how she looked. Okay, and then this was her photograph, let us say 2 years ago. Would you like to know any other information? Do we have any diagnosis? A full physical examination revealed Cushing's, right, very good, yeah. So Cushing's is an important cause of hyperandrogenemia and hirsutism as well. So that's exactly what happened here. So the complete examination was the only thing which revealed the diagnosis, and then we went on to biochemically confirm it. We also noticed that she had hyperglycemia and hypertension, and all of this was over 2 years, that's all. And investigations revealed that her 11 p.m. midnight cortisol is high. Normally, in the middle of the night, your cortisol levels dip. And then after you give exogenous steroids, your own steroid level should actually come down. But our patient was unsuppressed and the ACTH was high. We made a diagnosis of ACTH-dependent Cushing's, and she underwent a pituitary surgery, following which her hirsutism improved and her cycles resumed and her hypertension and diabetes resolved. So this is, she had many features of Cushing's syndrome, but sometimes the presentation can be mild. This is a 37-year-old software engineer. She was very clear that she's having unprovoked weight gain. She's saying, nothing has altered in my life, but I'm gaining weight. And she noticed increased hair growth and pigmentation. All three were her observations, and she was really adamant about getting a full evaluation done. So although she had no other features of Cushing's at all, no striae, no diabetes, no hypertension, nothing at all, but the evaluation did reveal that she had ACTH-dependent Cushing's, and there was a very small lesion, a 4 mm lesion in the pituitary, and then post-surgery, we noticed that her hirsutism and pigmentation settled down, and then she became a eucortisol. So even a mild hirsutism can sometimes be the first presentation. Usually diagnosis of Cushing's is missed for years. So probably we need to keep our eyes open and listen to our patients a little more. This is another young girl who presented with oligoamenorrhea for 4 to 6 years with acne. Notice that she has acanthosis around the neck, but her BMI is only 20.6 kg per meter square. We don't expect acanthosis in a person whose BMI is normal, and the hirsutism score is also 16 by 36. So this is a red flag here, that there is acanthosis in the presence of normal BMI. So this is a rare condition in which you have an abnormality at the level of the insulin receptor, because of which you have insulin resistance and acanthosis, and they can also present with hyperandrogenemia with the same symptoms. It's important to identify this because they are at increased risk of metabolic conditions like diabetes, steatohepatitis, and fatty liver. So if you find acanthosis in a girl who's normal BMI, although lean PCOS is a common condition, this is also something that needs to be flagged off and maybe referred to your neighborhood endocrinologist. So quickly to summarize, all women with hirsutism need a detailed clinical evaluation, which includes a detailed menstrual history, acne, androgenic alopecia, body contour examination, breast, scoring of the hirsutism, and presence of clitoromegaly. Earlier, the older guidelines said only do a testosterone level when the hirsutism score is more than 8. That's what the previous guideline said. But there is evidence to show that the score on the modified Fairman-Galway does not correlate with clinical conditions. The severity of hirsutism does not correlate with the underlying cause either. And some women might not have hirsutism at all, although their testosterone levels are very high. That is because there is a difference in the level of the sensitivity of the androgen receptor at the level of the skin to the androgen. So all women who present with hirsutism, even if it is 2, 3, 4, I think for our population, we should get an 8 AM testosterone level done according to the new guidelines. And suspect an androgen secreting tumor if testosterone is greater than 200 nanogram per deciliter, suspect adrenal source of DHAs is greater than 800 microgram per deciliter, and onset and progression are important. So if you're taking a look at the overview of the causes of hirsutism, 80% of hirsutism is likely to be PCOS. And probably the next most common is idiopathic hyperandrogenemia, where we don't know the cause. This is my last slide. But the sinister causes are some ovarian tumors, some adrenal tumors, congenital adrenal hyperplasia, and maybe even Cushing's syndrome. And those are the things that we need to pick up because the treatment of it is completely life-altering. So in a few weeks from now, we are holding Endocrine Society Satellite Symposium in Mysore. It's a beautiful city and it's a great time of the year. I welcome all of you. The theme for the session is pragmatic endocrinology. And thank you so much, ma'am.
Thank you, Dr. Chitra, for nicely describing the various causes of hirsutism in a nutshell. Can I have one question? Yes, ma'am. So, what is the best permanent remedy you will advise for an adolescent PCOS hirsutism?
Ma'am, this is completely outside the purview. The organizers will burn me with their eyes. He's burning me. Yeah, ma'am, we'll discuss it later maybe. Yeah, thank you, ma'am.
Good morning to all of you, and it gives me great pleasure, and I want to thank the organizers for this opportunity. And how do we assign a sex? When a baby is born, we just look at the external genitalia and we say this is sex of the baby. But I don't think for some it is that simple. And recently in the newspapers for the past 3-4 days, what you read is there is an international player which is fighting out for her rights, saying that she has to compete in the female group. So that is the complexity of the situation. And many a times we know about the genetic sex of the baby, we know about the genital sex of the baby, and sometimes even the psychological sex of the baby, now that the transgender group is a legal sexual group by itself. So now we have Dr. Shruti Chandrasekaran here to tell us what it means to be the endocrinological sex of an individual. And she's an American board, the previous slide. She's an American board certified endocrinologist and diabetologist and consultant endocrinologist at Rela Hospital and the IIT Hospital, and affiliated to the Endocrine Society of Tamil Nadu and Pondicherry, and as well as the American College of Physicians. And it's nice to note that she's been the best outgoing student from the Kilpack Medical College and also from the University of Maryland, Baltimore. Over to you, Shruti.
Thank you, ma'am. A very good morning to one and all, and thanks Trendo team for having me here this morning. What I'm going to be doing for the next 20 minutes or so is talk on the endocrinology. I'm going to talk about gender in a different perspective today and talk more on transgender care and what we do in our practice in the field of transgender medicine. I have no disclosures for this talk, no conflict of interest. The photos that I will be displaying are the photos of my patients. I have used them with their permission, so the photos are all used with permission, so please don't click photographs of that. I would probably request for that. So I'll start with, before I move to the transgender care, I want to start with 2 or 3 clinical scenarios to understand what we are actually discussing today. So we'll start with clinical scenario 1. So this is a 32-year-old girl. She's brought to her family physician. Most of the time they don't come to endocrinologist or gynecologist. They have a family physician whom they go to because she's not interested in marriage. So usually they listen to the family family physician. So the family takes her to them. And no medical history, not on any other, nothing is normal examination. So on further questioning and talking to her, she says that she's interested in female partner and currently having a stable female partner, which the family is not aware, and she's not ready for the marriage. So the basic cause here is she has a stable female partner here. So here, this is not a transgender. So this is just a sexual orientation. She's a normal girl, identifies herself as a girl, and she has a female partner. So sexual orientation is about who you are attracted to and you feel drawn romantically, emotionally, or sexually. A lot of times this gets confused when the parents bring their children or, they get referred to family practice. So it is important for us to understand the sexual orientation of gay, lesbian. Once you talk to them, you sort of get an idea of what the sexual orientation is. People can be bisexual. It is important to understand people can be asexual also. Even in transgender care, when we talk about the sexual history, a lot of them are not sexually active, right? It's okay to be asexual, which they call as an ace, no sexual attraction whatsoever. And some people would be just questioning or curious where they're unsure about their sexual orientation, or can be gender fluid as well. They could change from one gender attraction or the sexual orientation to the other. So when we see this, when we get the history from the patient, this is a very simple diagram that you can actually get it from online. I have this printed out and I explain it to the family because now a lot of these kids or, the adolescent group or college students are brought in by their families. So we generally explain that this is just a sexual orientation of what your girl is. It's either heterosexual, bisexual, or homosexual, and this has got nothing to do with transgender. So I want to start with a very basic case of sexual orientation before we go to gender identity or how you gender express yourself. So with this, I will move to the patient number 2. This is a 21-year-old Chennai student. Biological sex is female. Identifies as a boy. So this is completely different from the first case that I showed you. Boy, for as long as he remembers. So when we see this, using the right pronoun is important. I know the patient sitting in front of me is she. She could be she, but she identifies herself as a he. And I need to use the right pronoun. I need to go by whatever they want themselves to be called or how they want to be addressed and etc. So here, identifies as a boy for as long as he remembers. Not sexually active, no partner, but he's bisexual. No obvious medical or psychiatric illness. Family is based out of Trichy. Dad is a lawyer, quite influential person in Trichy. Clear treatment goals. She says he wants to transition to a male. That's all. That's why he has come to see me. So the question is, how do we proceed? So this is what is called as gender identity or transgender. A cisgender is biological sex, unidentified sex matches. For most of us, gender identity is a term used to describe the person's sense of being male, female. It could be neither. They will not identify themselves either sex or a combination of both. So you can go by the different names like transgender, transsexual, non-binary, eppadi vena kuppalam. Like transgender men is identify as men, recorded female as birth, like this patient that I showed you. Transgender women, I have another patient of mine I'm going to show in the next few slides, identifies as a woman, recorded male at birth. Male, but they want to be a female. So what do? First, they identify themselves as a different sex. They express or communicate. They could communicate to parents, they can communicate to friends, or they could communicate to their partner as well. So they come out with a gender identity. And what as clinicians or endocrinologists, what we try to do is align the physical characteristics with the expressed gender, transition, or whatever, what we call as a gender affirmation care. So we call it as a gender affirming hormone therapy or a sex reassignment surgery. So the question comes whether this is a mental health disease or an endocrine disorder. The simple answer is it's neither. Neither a mental health disorder nor an endocrine disorder. So we don't know what is going on. But it was initially called as a dysphoric condition, but it is not a mental health disorder. So I want that to be a very important take-home message. You know, we don't stigmatize these people. So we call them as a gender incongruent, and it's not gender dysphoria anymore. No endocrine or hormone causes are identified for transgender people, and we don't know why it happens. There's a lot of theories, but they think it's biological programming that happens at birth. Families' question is, from family's perspective, I can empathize from them, but I will not be able to answer, I don't think any endocrinologist can answer that to a point. So how do we diagnose? The desire to live and be accepted as a member of opposite sex, ready to accept hormone or surgical procedure. It should be at least present for 2 years, but most of these people that we see have been living this life for years together. The disorder is not a symptom of any. This is another important take-home message. It should not be a part of genetic disorder, or it should not be a part of DSD. Like androgen insensitivity syndrome, 5-alpha reductase, and genetic problems. They are all normal biological people who identify to have a cross-sex hormone therapy. So what we see in practice is 25 to 30% of them are denied treatment. A lot of times I also do some general medicine, primarily because of the reason I need to keep in touch, because a lot of times when they go and see doctors for even common cold, they get blamed for being on hormones for everything that happens in their life. So 25 to 30% of them are denied treatment, and they don't approach the doctor for the fear of discrimination, and there is a strict no for conversion therapy. Nariya parents, they will bring their kids and say, இவங்களை எப்படியாவது திருப்பியும் ஃபீமேலாகவே மாற்றிடுங்க, திருப்பியும் மேலாகவே மாற்றிடுங்க, எங்களால் எதுவுமே முடியாது. We cannot do that. And the Supreme Court is very clear, if you have seen the paper, the ruling last month which came out, very strictly against no for conversion therapy, and doctors who do conversion therapy in terms of hypnosis or whatever will be prosecuted according to the Supreme Court. They do have a higher percent of mental health disorders, suicidal ideas, substance abuse, metabolic disorders, malignancy, primarily because they don't get the necessary follow-up like the other people. So this is a patient who I showed you, biologically female. Or once you see them 2-3 years, you cannot distinguish. You cannot distinguish whether that person is transitioned or not. And a lot of times we see in both men to female and female to male, if we do the hormone therapy and follow them up and educate them on regular follow-up, the transition can be very beautiful. So this person was evaluated by a mental health professional. That's the first step. Most of the countries can have an informed consent and start treatment, but India, they have to be still evaluated by a mental health professional for the assessment of any other conditions. Family support is encouraging. Now we are seeing a lot of the social media is also helping in ways of, educating the family that, and kunja family members are coming forward to help people who are undergoing transition, which is a welcoming change that we see. We get a baseline investigations of testosterone, metabolic profiles, so that once we put them on testosterone therapy, we follow them up. So inga vande very simple. For a female to male, we put them on testosterone. Testosterone is a very potent hormone. Once you put them on testosterone, within like 3 to 6 months, the periods stop, the voice changes. You see a lot of changes like male. We don't really need anything else, right? And we follow them up every 3 months. So this is the changes that happens over, you can see the onset to maximum years of what happens, how in terms of voice change, vaginal atrophy, deepening of voice. As I told you, sometimes my receptionist will not be able to identify these people when they come 2-3 years, ma'am. Avangala ipdi aitanga. So it's very natural, the transition is. But this sort of duration will be educated to patients when they undergo the cross-sex hormone therapy or the gender-affirming therapy. And we also monitor them. It's not like I start them on testosterone and not monitor them. So we make them come every 3 to 4 months in the first year, monitor their hemoglobin, make sure the hematocrit does not go up. Polycythemia as a risk factor, is something that we see with testosterone preparation. We adjust that. And usually routine screening for osteoporosis is not required because most of them are hormone therapy. Only if they withdraw the hormones, I do evaluate for bone osteoporosis and other conditions. And these are some of the trans men well, we call them men, who are in different phases of transition. So these are periodic groups that we do, educating them about, it's sort of easy to educate as a group to tell them what they can expect out of hormone therapy and when they should come and meet us. So Avangala, they've been on hormone therapy for 3 years. They are running a transgender activist group called Trans Masculine Foundation. They've been helping a lot of people. It's a very close-knit group. They help each other, even financially. One helps the other, supports them until they find a job or give them place to stay. Sometimes when the parents don't agree to this and when they run from the family, they have a place to stay and they're provided food and everything. So we do have these periodic groups where we do the education part as well. So I will move on to patient number 3. So that is a trans man, the case that I showed you. I'm not showing you the detailed process of testosterone therapy because that is something that would be beyond the talk for today. So this is a 22-year-old male, internship in a private medical college, gender incongruent, identifies as a girl. So she's in a final year medical college right now. She wants to have a slow transition. She wants to come out of the medical college and then, have the transition process complete. So that's the beauty of hormones. We can dose it according to how they want it, how soon the transition is required, how we will monitor the hormone transition in a way we give them the hormones accordingly. Normal pubertal development, no other. Again, similarly bisexual, no stable partner, occasional smoking, no alcohol or no drugs. So this is a patient, this is the patient who is currently 3 years of hormone therapy, the same patient that I showed you in the clinical case. As I told you, it's very hard to distinguish after transition. So all these 3 years, this lady has been only on anti-androgen therapy and estrogen. Only last week she went for an orchidectomy, right? Even without orchidectomy, and she was also on GnRH analog. So she did go through a couple of treatment, block the testosterone, and this is how she looks now. This was before, this photo was taken before the orchidectomy. And in trans women, the major thing that we use is anti-androgen. The most common thing is aldactone, which works very well. Gives them this contour, the breast shape, gives them very nice skin and glow to the face and hair growth on the scalp. Along with that, they also meet dermatologists, go for laser therapy, whole body laser, or depending on where they want facial hair reduction. And this person who underwent the hormone therapy was also on GnRH injections, started monthly once to completely block the testosterone, and then later on switched to 3 monthly GnRH. Now, since she had orchidectomy, I would stop the GnRH and aldactone. I would only continue estrogen therapy. So she is also on estrogen. The usual dose of estrogen that we use in transgender care is up to 8 milligram, which is quite different from the normal premature ovarian failure or the other conditions of estrogen. Here we do a very graded upgradation of estrogen. We do educate them about the risk of venous thromboembolism. Even though luckily I have had some of my colleagues who have seen thromboembolism. So we go in a very graded manner. I usually ask them to avoid any over-the-counter estrogen supplements or anything that they could do other than the one that I'm prescribing them. And we usually ask them for a smoking cessation because that's also something we see a lot. Ask them to go for smoking cessation, educate them the danger signs for thromboembolism. But the maximum estrogen that I've used in her is about 6 milligram. I have not gone up to 8 milligrams of estrogen in any of my patients because I'm very scared of thromboembolism. But with 6 milligram is the transition that we see. And as the trans men, even in trans women, we do periodically monitor them in terms of the estrogen, prolactin levels, making sure that we're not doing over-toxicity or giving them a higher dose causing side effects. And we do have a published guideline from Journal of Endocrinology. Our guidelines are there from Endocrine Society of how to monitor them and what frequency. We do educate them during the follow-up. So this this lady doctor now, she's on anti-androgen. She went for GnRH, estradiol. We do measure the estrogen level and total testosterone. Now that she has done orchidectomy, I don't have to worry about the total testosterone level. Voice treatment. In the transition, the voice will never change. She will look very feminine, but the voice will be still male. But in the other transition, the voice changes beautifully. After 3 months, when you talk to them over phone also, you will not know whether it's actually a she who has converted to a he. Here, the voice treatment has to be undergone. We need an ENT surgeon for vocal tracheal shaving and voice speech therapy for voice treatment. A lot of them undergo that procedure and go for a self-voice treatment. They will need a lot of other cosmetic procedure, but this person has not undergone any reconstructive surgery. All she has done is laser therapy for her face, and she was on anti-androgen and GnRH, but she has not even done breast augmentation surgery. Some of them go for silicone breast implant and also go for sexual reassignment surgery. So I have about 3 minutes more. So I have last few slides. With this I'm done. So the treatment for transgender, as I told you, it's not everything for everybody. We don't throw in everything that I showed you in this slide. Like for example, we don't offer all these things to a particular patient. It takes a lot of time from my perspective to actually talk to them and understand what they want. ஒரு சில பேருக்கு வெறும் ஐடென்டிட்டி சேஞ்ச் மட்டும்தான் வேணும். Just call me, like for example, don't call me Ovia, call me Ovian. That's all they want. They don't want hormones, they don't want sex reassignment surgery, எதுவுமே வேண்டாம். வெறும் ஐடென்டிட்டி சேஞ்ச் இருந்தால் போதும். So we respect that and we do only identity change. We don't put them on hormones or ask them to come for follow-ups and etc. Some transgenders want only hormone therapy and no surgery. So this person went orchidectomy, but a lot of them don't go for orchidectomy, right? So we are aware of what is left anatomically, so that when that particular person crosses 40 or 45 years, I know I need to do cancer screening. None of these hormones increases the risk of cancer. We are just putting them on cross-sex hormones. But we start doing age-appropriate cancer screening, how we regularly do for men and women. And the madre, we do routinely screen with mammograms. If prostate is left, we do get a PSA. I don't have that old patients. I don't have much experience in terms of cancer screening. But I'm telling you, if the anatomical part is left, we do go for cancer screening as well. Even in surgery, they prefer what they want. Some trans men only want mastectomy because they get socially abused in the workplace. So adanal a lot of them go for mastectomy just to reduce the risk of abuse in the working condition. And some of them don't go for hysterectomy or oophorectomy. They don't go for any other procedures. Similarly, in SRS as well, in trans women, some only go for orchidectomy. They don't go for any other plastic procedures. So even in surgery, it's totally up to what they want. It's not like what we offer to them. And most of them are well educated. They know how to go for treatments, etc. So the question is how long to continue gender affirming treatment? Usually until the age of menopause. Natural menopause or natural andropause. That's one way of looking into it. Somebody is around 50, I don't have that old patients. I would talk to them and say that now it's a time to actually stop because you would go for anyway a natural biological menopause at this age. But again, if they are ready to continue, you can continue it. Some guidelines say even 55, 58 with close monitoring of the metabolic condition. So my overall experience with transgender medicine, with this I finish. There is an improvement in psychosocial measures after gender affirming treatment. A lot of them do very well in society. I have lawyers, I have police officers, I have activists. A lot of them do really well socially after they undergo transition. Psychologically, they do a lot better. Not all transgender people seek all interventions. Some may seek none. As I told you, they want only gender identity. In contrast to past practice, when I was in endocrine training in the university, we used to have 1 half a day dedicated for transgender care. We used to do psychological assessment, hormones, surgery. That pathway is no longer there right now. They can pick and choose what they want. The current standard of care is to allow each transgender person to seek only the intervention which they desire to affirm their own gender identity. So with this, I finish with this quote. Usha also showed this quote yesterday. The 2 most important days in your life are the day that you're born and the day you find out why. I think the practice of transgender medicine is something that I really enjoy doing, even though it's a lot of work, and it probably tells me the reason of why I was born. Thank you.
That was a beautiful way of putting the thoughts of a transgender person and how you approach them clinically. Hats off to you, Dr. Shruti.
Thank you.
And
Thanks.
I just have one question.